So as Saki said, I'm Mark Johnston. I'm used to be a medical doctor as well. And I'm currently working for NHS Rightcare, and I'll get into explain a little bit about that in a minute. What I want to talk to you about first of all, I've tried this lots of different ways. The least effective is just read the screen, because obviously at the back you cannot. I can barely read it from here. I've tried to memorise it, but then I miss bits, and I try to summarise it, and I miss the important bits. So what I'm going to do is I'm just going to read this out to you, and it'll hopefully make sense. So this is Paul Adam. He's a 45-year-old bricklayer. He's married to Wendy, who's a barmaid, and they've a 16-year-old son called David. Paul supports his local football club, doesn't exercise too much and smokes 10 cigarettes a day and drinks around 4 pints. He's overweight. The family lives in a village where there's limited food options, and the GP is 17 miles away from the local hospital. Paul's journey starts when Wendy's nagging him about his lack of energy, increased urinary frequency, and his GP performs some tests and confirms he has diabetes. Initial management is with diet, exercise and pills given out by the GP. He has 6 visits to his practice a year and 6 lab tests a year. 5 years later, Paul's now 50. Still drinking but given up smoking, not managed to lose much weight. His recreation is watching football and going to the pub, which on every night except tonight is not the best way to do things. His leg hurts and he's been on insulin for a year. Paul's not walking far, he struggles to drive and he's missing work. He's been referred to hospital for diabetic opinion and vascular surgeon. Wendy has to drive in most places now and David's going to university. 2 years later, Paul's 52. He has significant heart and renal complications, his vision is deteriorating, Paul loses his job with little chance of retraining and applies for suitable housing. Wendy has to give up her job. 2 years following that, Paul gets a sudden acute onset of a painful white leg. A couple of days later, Paul's leg is amputated. That version of Paul's journey cost £49,000, and that's without the obvious impact on the individual, the family, social care, and the wider sort of society in terms of jobs and the impact on the family. So what Paul's CCG did was they looked at one of the variation packs, which I'm going to talk you through from a Rightcare perspective, looked at populations, and we talked lots about populations today, but looked at populations of people similar to Paul. People either at risk of diabetes or currently have diabetes, and looked at how they varied against their peer groups to see could they do things differently. So what does Paul's journey look like now? At his annual health check, Paul's diabetes is picked up 1 year before it would have been otherwise picked up. He's immediately referred to a specialist clinic where they support him around diet and exercise, not just advise it, support him to make the right food choices, get him involved in local clubs, and get him exercising, and Paul managed to lose some weight. He has a care plan, he has regular medication, he has retinopathy screening, which is brought forward 18 months before the first time where his vision deteriorated. He's supported with self-management using the Desmond programme. He regularly attends his local diabetic support group. Paul's now well. This journey cost £9,000, and that's the difference between a poor pathway and a good pathway. Now, how we pick that up and the relevance to population healthcare is what I'm going to talk you through now. So Rightcare is a national programme. There's been lots of changes, and like the rest of the NHS, we now function through NHS North on a regional basis. But we look at populations, and we talked about populations, about whether it's the 1.7 million, whether it's England, whether it's Croatia, but we look at the population from the point of view of programmes of care, based on public health programme budgeting categories, but it's around disease-specific programmes. It's like populations such as the one Paul is a part of, and comparing that population to similar CCGs. And we use that variation to get people talking about the same things, to understand how you're currently doing as a system, and to focus on areas of the greatest opportunity. And I'll come to what that might look like for Cumbria and Lancashire in a second. So this is, everyone has their sort of plan on a page. This is what we do from a Rightcare perspective on one page. So we're going to wind. I've been told I have to stand in one place. I was tempted to keep drifting that way. So where to look, I'm going to talk a little bit about more to where to look at the minute, but it is using the variation in populations, and I'll talk about how we define those populations and how that the peer groups work in a second. Then what to change. We've heard lots of really good examples, both nationally and internationally, and Surrey and Heartlands, Bruce, one of my colleagues, works with them, about the what to change. And we've got workshops this afternoon that's going to focus on a little bit of the how to change, but that's sort of getting everyone together, having good, strong processes, having a consistent approach to healthcare improvement, population improvement. And then along at the bottom is indicative data. Let's get away from arguing about the data and start to see what those patterns may show. And we talked earlier, some colleagues, about clinical engagement with the wider community, and Surrey Heartlands have obviously done a great thing with their sort of panel of 3,000. I mean, I think that's fantastic. And effective improvement processes, which is the commissioning, the provider, bringing the care systems together, having a consistent approach, including digital solutions about how we do things. And what we try to do in Rightcare, when you're faced with variation, is not try to justify and explain. If someone says you're different or you're worse, your immediate response is to take a position and defend why that may be the case. I speak about Blackpool because I used to work there, both as a doctor in the acute trust and as a commissioner with Amanda. And I was part of the same thing. What we tend to say is, well, your outcomes in cardiovascular disease are really poor. Immediate response is, well, that's the population. But then when you get a benchmark peer group with the same population as Salford, St Helens and Knowsley, actually they have really deprived populations, but they spend a lot less money and their outcomes are a lot better. Could we do something different? And it just changes the conversation from blaming populations or blaming patients to saying, well, if similar patients and populations can have better outcomes, often spending less money, then maybe we could do something differently. So we're trying to get people focused on, does this represent an opportunity to improve? So what's slightly different about Rightcare versus a lot of other tools that are out there and data sets is how we compare and benchmark CCGs. So there's 10 demographically similar CCGs, which is your peer group. So within a health system, you can be fairly confident that the CCGs you're being compared to have similar challenges, whether that's racial makeup or age profile or risk-taking behaviours. We've tried to encompass all that so that it takes you away from the argument it's the patient's or the population's fault and shifts it into, could we do something different? I just wanted to talk specifically about Lancashire and South Cumbria and some of the opportunities they have. So you probably can't read all these figures, but the programme categories we look at, and this is some of the larger selection, but it's the ones that Rightcare have sort of done all the work on, is cancer, neurological, circulation, respiratory, GI and trauma and injury, and this is lives saved. So there's 500 lives could be saved out of our 1.7 million that other similar health economies are able to save. How different are we in bed days? And Amanda talked about resource, and beds obviously a massive resource. In Cumbria and South Cumbria and Lancashire, there's nearly 200,000 bed days more than similar CCGs elsewhere in the country. And that's just to get to average. That's not an internationally best comparison. This is to get to average of your average peer group. 200,000 beds. That's over 500 beds if they were used 365 days a year. That's a hospital more than our similar peer groups would have elsewhere in the country. So I don't feel it's about resource, it's about how we use that resource. Primary care prescribing, I don't pick out, I press escape. We're going to have a competition about who's best with this. So pick out respiratory. The prescribing spend respiratory versus the peer group is £4.5 million more than our similar peer group. And that's, yeah, put me there, that's fine. Primary care prescribing, so £4.5 million, that's the biggest opportunity in terms of how we spend that money. And you could argue, well, actually, spending lots of money on medication may be a good thing because it's preventing people becoming more unwell, improving outcomes and preventing secondary care spend. But then we look at our non-elective admissions in respiratory, it's our biggest opportunity to improve. So compared to that peer group, we're spending a lot more money, in theory, preventing people going into hospital and remaining well on medication, but actually then we're admitting them all to hospital with the same disease. In terms of elective admissions, there's one obviously very large one, and that's MSK. So why in Lancashire and South Cumbria do we spend nearly £18 million more than similar CCGs elsewhere in the country? And this is a decreasing figure because it used to be closer to 20. So we've done a lot of work, and we need to continue to do work to understand what are the pathways that mean that people end up having elective orthopaedic procedures versus what else is needed in the community. Is it the third sector and support around exercise and well-being and staying, getting moving? Is it around pain support in primary and community care? What are the things? And this is just a series of questions that gets you into some of the more detail around these opportunities. But I don't feel it's about resource, it's about how we currently utilise that resource. So what are we doing across the patch? This has been running nationally for probably about just over 3 years. I've been here for 2 years supporting the patch. Up in Morecambe Bay, doing lots of work on MSK, neurology, CVD, gastro and cross-cutting, and looking at their data that they're producing locally, they're seeing the impacts of, we can see we're very different in elective orthopaedics. Meeting with the key stakeholders, patients, patient groups, clinicians, to understand what do they need differently. Well, it seems there was an open tap flowing from primary care into secondary care. What do we need to do? We need to start to sieve some of those patients out that aren't appropriate to go to secondary care, and they're seeing big inroads in terms of the positive impact on MSK. Similarly, Pennine Lancs, when the Rightcare data packs came out, they could see a massive variation in back injections. You think, well, how much could we spend on back injections? £2 million more than their peer group for the Pennine Lancs LDP. So they've now worked with and it turned out to be one single provider and not very many more than that clinicians that was driving this. So they needed to work with the local clinicians in terms of why the patients were having to receive that treatment, worked with the Royal College of Surgeons to understand what sort of policy would support the correct procedure, the correct pathway being provided for these patients, and they continue to work on that. But without Rightcare, they could just see they spent £5 million on back injections. They had no idea whether that was too much or too little. But with Rightcare, it just gives you that comparison to get into some of that detail. Central Lancs doing some good work on the cross-cutting themes, looking at lots of different prescribing options, and MSK as well, which you saw from the slide before, that it is a massive opportunity. And what the Central Lancs CCGs are working on is something called CROC, and it's not those funny shoes, or another version, a less nasty version of an alligator. It's coordinated reallocation of capacity, and the term is stuck just because it's daft. That classically as commissioners, we will do a project or a programme of work, implement it, then 2 years later, actually the activity problem was bigger than it was before. Why did that happen? Sort of squeezing the balloon in one area, gets bigger somewhere else. This is about coordinating. So you did all the right inputs. Why wasn't the outputs right? And it's a tool to track some of that through. I'm almost done. West Lancashire doing some great work around shared decision making. Fylde Coast, some very interesting stuff in cardiovascular disease around non-ST elevation MI. And again, without the Rightcare variation lens to view this through, you wouldn't have seen, why do we have 3 times as many admissions for non-ST elevation MI? It's not because we've got a greater disease burden, it's because the pathway is wrong and they go to 3 different hospitals for one disease. And we're charged 3 times, and we've got 3 lots of activities. So we're supporting, working with the cardiothoracic surgeons and the commissioners to try and smooth that pathway out, which means the patients get the right care at the right time. And finally, just the North are looking at respiratory as a whole, and Rightcare is supporting that with all the CCGs through the Urgent Emergency Care Network. In winter, we've got lots of problems. When you look at respiratory, as a clinician, it was exacerbation COPD at winter. I assumed that's what the problem was. But when you look at the data, The biggest variation is around flu and pneumonia admissions. Actually, large parts of that are preventable, and the population that we don't address are the ones that need it most. So how do we do that differently? And I will leave it there.